presentations. Next up, we're going to have Dr. Parag Patel present on healthcare resource utilization and outcomes among patients with intermediate risk PE treated with computer-assisted vacuum thrombectomy.
Thanks, Ehrin, and thanks to the VIVA committee to present on behalf of our multidisciplinary, authorship group. Sorry, we don't have the full author line here, but the group of us looked at health resource utilization as it relates to PE, and I'll present this first of its kind sort of a data analysis. As we all know, PE incidence is quite high, and estimates that are at about 300,000 PE cases in the U.S. annually. And we believe that estimates suggest 40 to 60,000 deaths per year related to PE, and approximately 157,000 of these patients are deemed intermediate high or high-risk patients. However, only about 20% of these are offered or treated with advanced therapies, as by all best estimates. And that's despite the fact that advanced therapy in PE has demonstrated beneficial effects, specifically with relation to reduction in RV-LV ratio, as well as reduction in pulmonary artery systolic pressures and overall improvement in mortality. Additionally, further new generation devices and techniques have improved the efficiency of treatment, reducing blood loss, shortening treatment time, and reducing complication rates. So the study group, or the authors, looked to perform a retrospective analysis in conjunction with the Vizient clinical database. And we look at to utilize that large database to look at resource use and health outcomes of patients with intermediate risk pulmonary embolism treated with CAVT, or computer-assisted vacuum thrombectomy, specifically with the Lightning 12 and Flash 1.0, and compare that to other treatment modalities, medical management, anticoagulation, catheter-directed thrombolysis, or other mechanical thrombectomy. A brief word about the Vizient clinical database for those that aren't aware. This comes from the Vizient GPO, which is the largest group purchasing organization in the US and accounts for approximately 42% of all claims, and encompasses over 1,300 hospitals in nearly every academic medical center, over 50 healthcare systems, and over 750 community hospitals, and can provide comprehensive data, specifically administrative billing data and clinical resource utilization data, and accounts for a significant number of inpatients and outpatients each year. It's also important to note that the Vizient clinical database utilizes a separate company, SG2, to perform all data analysis, data processing, and statistical analyses of this data. So the group can query, but specifically is not handling any of the raw data per se itself. A study methodology utilizing the Vizient database was to look at adult patients with intermediate risk PE during our study period between 2020 and 2023. We used ICD-10 codes that corresponded to pulmonary embolism, with or without cor pulmonale. And we tried to exclude massive pulmonary embolism patients utilizing proxies for this. So that is patient encounters where vasopressors were instilled, or those that experienced cardiogenic shock or required CPR prior to intervention. Of course, interventions were then mapped to their corresponding MS-DRGs, so we could identify patients treated with CDL or mechanical thrombectomy. And then we utilized specific product SKUs to identify the Lightning and Flash 1.0 to tease out the CAVT patients, and all other patients were then deemed mechanical thrombectomy. And so with that, we had 4 subgroups included: CAVT, specifically looking at the Lightning 12 and Flash 1.0. Second group of catheter-directed thrombolysis, and that was all comers, catheter-directed lysis as well as ultrasound-assisted catheter-directed lysis. Other mechanical thrombectomy, that excluded CAVT, and then anticoagulation. And of course, we wanted to eliminate low-risk PE patients, so any patient that had absence of a procedure code and had elevated troponins were included. Otherwise, they were deemed low-risk PE patients. Furthermore, we excluded patients that had more than one procedure, as the purpose of the study was not to look at mixed treatment modalities, and we excluded those that were treated with systemic thrombolysis. Within our time period, there were over 34.5 million patient encounters and 184,000 PE diagnoses. When you take into account the inclusion-exclusion criteria that was applied, we saw 520 patients treated with CAVT, over 2,700 patients treated with catheter-directed thrombolysis, over 9,000 patients treated with mechanical thrombectomy, and over 3,900 patients treated with anticoagulation. To eliminate inherent selection bias, we instituted a propensity score match at a 1-to-1 ratio utilizing patient demographic data, specifically age, sex, and race, as well as looked at comorbidity index, specifically this Alex-Hauser comorbidity index, which incorporates 38 different comorbidities to assign an index value for each of these patients. When the propensity score matching was applied, we ended up with a total of 2,060 patients, 515 patients in each of the study arms, as seen here. With that, we can see our patient demographic data. There are gender differences across all 4 treatment groups, but these are essentially similar. There was a statistical significant difference in race at CAVT compared to the other treatment groups, and age was fairly similar. I don't think clinically significant, however, there was a statistical significance between CAVT implementation and anticoagulation. The other 2 treatment arms were similar. When we look at primary outcomes, specifically we wanted to look at length of stay, percent of ICU, discharge summary, and complication rates amongst these to get a better sense for healthcare resource utilization and economics. If we looked at length of stay, the mean observed length of stay was significantly shorter for the CAVT cohort when compared to anticoagulation, CDL, or other mechanical thrombectomy, so significantly less when compared to each of those study groups. When you take into account post-procedure length of stay, so to take into account the fact that maybe procedures didn't occur on the first day of admission, we can still see that there was a significant reduction in the CAVT cohort with regards to length of stay as compared to CDL or other mechanical thrombectomy. As you might imagine, ICU utilization rates are going to be different as well, the CDL group having the highest rate of utilization of ICU admission and length of stay. The CAVT group, while some ICU admission was utilized, as these were sicker patients, this was comparable to the mechanical thrombectomy and significantly lower than that of CDL, as was the length of stay. It is important to note that the anticoagulation cohort had less ICU length of stay and admission comparatively. When we look at complication rates, the Vizient database has a predetermined metric, a composite complication rate that they measure for all procedures, regardless of treatment modalities in any sector of evaluation within their database. The composite complications include a number of factors, most relevant ones listed here. When identifying complication rates, we see that the CAVT cohort had the lowest complication rates compared to all 3, but it was only statistically significantly less than compared to other mechanical thrombectomy. Specifically looking at acute kidney injury, we identified an area that was, while we see acute kidney injury in PE patients, we found a statistically significant difference in CAVT use compared to catheter-directed lysis and mechanical thrombectomy. Further investigation to identify why this might be is certainly necessary, but a finding we wanted to share. And I think furthermore, and probably just as interestingly as the other data we've reported, the discharge disposition of patients treated by different treatment modalities was studied as well. I think an important factor of this type of data analysis. Similarly, across the anticoagulation, mechanical thrombectomy, and CDL groups, we saw home discharge roughly in the mid-50% range with a significant number of home health care utilization and a corresponding discharge to skilled nursing facilities or long-term care facilities. And we saw a significantly different reduction in discharge to skilled nursing facilities and a significant increase to discharge to home with a reduction in utilization of home health services. So certainly an impact with healthcare resource utilization. So in summary, our retrospective analysis of the largest group purchasing organization clinical database, Vizient, identified improvements in clinical outcomes and reduced healthcare resource utilization with advanced therapies, specifically as it relates to ICU stay and admissions. But specifically as it relates to CAVT, we saw significantly lower composite complications compared to other mechanical thrombectomy, significantly lower rates of acute kidney injury, and the highest rates of discharge to home with the lowest rates of home health support required. I think this is the first of its kind study that helps provide additional support beyond just the sort of short-term cost analysis of device costs and overall starts to look at the greater picture, if you will, with regards to patient journey through the healthcare system and ultimately to home. Thank you.
Parag, Great presentation, congrats.
Thanks, Raghu.
There are more and more of these large data sets, MSDRG-based and coding-based data out there. What do you think is the reason for CAVT to have better outcomes? I guess we could hypothesize things about the complication, composite complications, but how do you think CAVT led to lower SNFs compared to other thrombectomy devices? It's a little, I'm curious about that.
Well, I think this is the first of its kind looking at this with regards to healthcare resource utilization. I think the initial purpose, or at least for me as a primary author, but also the author group, which really is a multi-specialty group invested in PE outcomes, wanted to see how can we support further advanced therapy utilization in intermediate risk PE patients, thinking that there is a benefit for that overall. And obviously the study design was to look at each of the different cohorts as opposed to lumping all advanced therapy into one. So I think there was a little bit of a surprise. We didn't know the answer in advance. We just wanted to see a benefit compared to anticoagulation, and is that shared across advanced therapy treatment outcomes. Obviously the findings were the findings. We don't have the raw data set. We have to specifically ask targeted questions to the SG2 group that then does the data acquisition and analysis from the Vizient database. And so further questions or hypothesis generating questions can come out of this to try to tease out why might this be the case. But with large data sets, you start to see signals for things that might be a benefit for further investigation.
Thanks.
Fantastic work, and I think this is our future for interventional medicine. One of the issues is different procedural endpoints for various devices, and I wonder if you looked into that and whether some of that might explain the differences in potential outcomes.
Yeah, that wasn't specifically looked at. That's a hard thing to capture within the Vizient database, is the endpoints of that intervention. I mean, while there is power in data, there are some limitations as to what the data set can provide you. So we didn't have that specific endpoint to investigate.
Parag, was there any granularity in terms of drilling down on the specific complications? I mean, I'm really struck by the significant difference here between CAVT and mechanical thrombectomy. Were you able to figure out, was it due to the fact that the other mechanical thrombectomy devices, perhaps were bigger and bulkier and there were more access complications, or perhaps, navigating the 24 French system through the right heart? Were you able to figure out what specifically was more likely, what complication or complications were more likely to occur with the other mechanical?
Yeah, that's a great question. As I showed you, the composite complication is how they present it. I think they're not trying to allow investigators to weaponize the data to look at specific outcomes, but then you can ask for follow-up specific questions. And so you sort of have to know the right questions to ask in the data sets. And so we asked obvious questions that we thought we might want to look at, specifically the acute kidney injury one, which did bear out to be a significant difference, so I presented that. But actual specific complications, now access site complications aren't necessarily captured in that composite complication rate, but readmissions and other factors are. So those specific types of things that might be a proxy for that are things that we can ask and further query the data set.
Transfusions?
Correct.
Transfusions,
Right.
blood loss, those type of things could be obtained in Vizient, I'm sure.
Parag, congratulations on your study. Excellent summary of it. I think I do want to highlight that, yes, inherently there are these issues with querying large databases that you cannot drill down onto patient level information. And perhaps that's one of the major deficiencies of looking retroactively at this. It's also important to highlight the need for more information, for example, from PE tract, to really understand what are the nuances of each of these devices. Congratulations.
That's a great point. Thanks, Jim.
Great, thanks very much. Great presentation.
Thank you.